Petechiae and purpura. Key points. The majority of children with petechiae do not have a serious bacterial infection or meningococcal disease, and often will not have a specific cause identified. Seriously unwell children with petechiae/purpura require urgent management. Background. Serious bacterial infections including meningococcal disease can present with a non-blanching rash, with or without fever. The incidence of pneumococcal and meningococcal bacteremia has decreased since the introduction of routine vaccination. There are many other infective and non-infective causes of petechiae and purpura, see table below. Definitions. Both petechiae and purpura do not blanch when pressure is applied. This is in contrast to other common rashes in children such as viral exanthems and urticaria. The glass test can be used to assist with assessing whether a rash is blanching. A drinking glass can be applied firmly against a rash. If the rash does not disappear, it is non-blanching. Image. Petechiae are pinpoint non-blanching spots. Purpura are larger non-blanching spots, and GT2 mm. Image. Petechiae on the torso and legs of a child. Image. Purpura on the torso and back/face of a child. Assessment. All children with fever and petechiae/purpura should be reviewed promptly by a senior clinician. History. Immunization status, children and LT 6 months of age or with incomplete immunization status. Rapid onset and/or rapid progression of symptoms and rash. Medications. Prior treatment with antibiotics may mask signs of a bacterial infection. High-risk groups, immunosuppression, previous invasive bacterial infections. History of trauma/injury. Association with bleeding, abdominal pain, joint pain, difficulty mobilizing. Travel. Sick contacts. Examination. Children are considered unwell when they have abnormal vital signs, tachycardia, tachypnoea, and/or desaturation in air, cold shock, narrow pulse pressure, cold extremities, prolonged capillary refill, warm shock, wide pulse pressure, bounding pulses, flushed skin with rapid capillary refill, altered conscious state, irritability, inconsolable crying or screaming, lethargy, including as reported by family or other staff, limb tenderness or difficulty mobilizing. For all children, also consider hematological causes and review for hepatomegaly or splenomegaly, lymphadenopathy, swelling or erythema of joints. Differential diagnoses. Causes of petechiae and/or purpura. Viral. Enterovirus, adenovirus, influenza. Bacterial. Streptococcus pneumoniae, Haemophilus influenza, Group A Streptococcus, Staphylococcus aureus. Mechanical. Vomiting or coughing, occurs in the distribution of the superior vena cava which is above the level of the nipples. Local physical pressure, e.g. holding child during procedure, tight tourniquet, blank, or accidental injury. Hematological. Blank, ITP. Malignancy including acute leukemia, aplastic anemia, disseminated intravascular coagulation, DIC, hemolytic uremic syndrome, HUS. Other. Blank. Drug, vasculitis. HSP. Drug-induced thrombocytopenia. Note, there are additional causes of petechiae that should be considered in newborns, e.g. congenital cytomegalovirus, toxop, neonatal lupus. Any newborn with petechiae should be promptly reviewed with a senior clinician. Management. Flowchart. Asterisk senior clinician review may lead to decision-making pathways outside of this flowchart, including the role of investigations. If a senior clinician is unavailable, the safest approach is to manage according to the flowchart. Film must be reviewed to exclude an alternative diagnosis. Blank. Cefotaxime, 50 mg per kilogram, 2g, 412h, week 1 of life, 6-8h, week 2 to 4 of life, 6h, and week 4 of life. Ceftriaxone, usual 50 mg per kilogram, 2g, 4 daily. Severe, including meningitis and brain abscess, 100 mg per kilogram, 2g, 4 daily or 50 mg per kilogram, 1g, 412h. Where possible, ceftriaxone should be avoided in neonates. 41 weeks gestation, particularly if jaundiced or receiving calcium-containing solutions, including TPN. Flucloxacillin, 50 mg per kilogram, 2g, 46h. Consider consultation with local pediatric team when assessing any unwell child, including any with suspected meningococcal disease. Uncertainty about diagnosis or to arrange follow-up. Advice regarding escalation of care. Consider transfer when child requiring care beyond the comfort level of the hospital. Blank. Consider discharge when serious cause of petechiae/purpura considered unlikely based on clinical assessment and/or investigations. Always advise parents to return for review if their child becomes more unwell or there is concern.